Doctors and nurses, what dirty hospital secrets you don't want your patients to know. Story 1. What do you call a person who is at the bottom of their class, barely graduates, and has cheated through his doctoral and medical exams? Doctor. One of my friends, a former intern at a hospital in D.C., told me that many of the doctors he worked with were, in his words, bottom of the barrel when it came to skills. In this area, specialists in private practices make far more than those working at hospitals. He said some doctors barely had the necessary competence to keep their jobs and only did so by gaming the system rather than improving their skills. He also mentioned that some physicians and nurses had questionable international accreditations. Although these were recognized by the AMA, they flooded lower-paying positions with good enough ratings, helping to fill staffing gaps in desperate situations. He also told me that many doctors hated their jobs and disliked patients even more. They became doctors mostly due to family or societal pressures, viewing it as a symbol of success rather than a calling. The kind of doctor who charges your insurance $300 for a visit where they just check your pulse might resent the overbearing parents who pushed him through medical school in Pakistan. Now half of his paycheck goes to them, even though they're unloving and ungrateful, using his job as a status symbol among their friends. Screw you, mom and dad, and screw you too, middle-aged woman with cancer. You think your family really loves you? No, you're just a tool to them. You swallow their shallow affection while ignoring me, the guy who can't even pronounce his last name right. Screw my life, now I'm going to recommend a catheter, not because you need it, but because I want to see you squirm. He also mentioned how much influence pharmaceutical companies have over doctors. My sister, a dental hygienist, told me her boss is paid for 2-week vacations in Hawaii by dental vendors for conferences which are just thinly veiled sales pitches for their products. My friend, who's a phlebotomist, said she's attended these same conferences where her doctor boss, who is disillusioned by the healthcare system, pointed out which classes were just glorified sales presentations. Her boss is the kind of doctor these conferences despise because she asks intelligent questions that the lecturers, who often have minimal medical training, can't answer or are woefully unprepared for. Before we continue, do us a quick favor, smash that like button and subscribe to support our channel. Story 2. There's a dirty secret in healthcare that not many people are willing to acknowledge. Let's say you go to the hospital with chest pain, and your doctor orders pain medication for you. Somewhere along the way, a mistake happens, and instead of pain meds, you're given something like nausea medication. In most cases, you likely won't be told directly about this mix-up. The provider will document the error correctly, file an incident report, and inform your doctor, but they won't explicitly tell you, "I made a mistake," or note in your record that you were accidentally given the wrong medication. This is partly because telling you could cause unnecessary anxiety. Additionally, if something goes wrong, the documentation is there for you to sue the hospital, and the last thing they want is to hand you a winning lawsuit on a silver platter. And honestly, we're all human, mistakes happen despite our best efforts, but many times these errors are benign and don't cause harm, so if nothing goes wrong, there's no real reason to point it out. Story 3. I work in a NICU, and it's honestly terrifying how some of my coworkers don't know basic things they should. They're often just hoping that nothing serious happens while they're on shift, instead of actively monitoring and looking out for warning signs. Last week, a new grad didn't check a baby's IV site for 12 hours. By the end of the shift, the parents noticed their baby's leg was swollen and asked the nurse about it. Turns out, the nurse had missed checking the IV site, and over the course of 12 hours, fluid had infiltrated into the baby's leg. This all happened right around shift change, so I don't know what happened to the baby after that, but we're supposed to round every hour and check every line carefully. If something goes wrong with an IV, you can tell well before 12 hours, and if it's bad enough, you could end up losing a limb. It's basic stuff that should never be overlooked. Story 4. The biggest secrets where I worked were all the affairs. There were a lot of them. Every so often, I'd walk into a room with a female CNA or nurse, and some of the older ladies would comment, "You two make a wonderful couple." I'd laugh it off, but I knew what was really going on behind the scenes with a few employees. One nurse even turned the dining room into a candlelit date night for a special someone, and let's just say things got pretty heated that evening. There were plenty of makeout sessions, some inappropriate touching, And even instances where I'd run into employees out in public, getting a little too cozy. Nursing homes and hospitals can be full of drama, but it's not always because of the patients. Story 5. I'm an ICU nurse, and it honestly breaks my heart to say this, but doctors sometimes flat out lie in their notes. You'll read things like, "I personally spent 30 minutes in face-to-face evaluation of this patient." No, you didn't. "I've been at this patient's bedside all day, haven't had a proper lunch, and only managed to pee once, and not once did I see you step foot onto this unit." Another example, a patient was admitted due to concerns about limb ischemia. The doctor's note said the limb was warm, so collateral circulation must be adequate. I cared for that patient for 3 days straight, 12-hour shifts each day. That limb, it was never warm. It was cold every single time I assessed it, and the circulation was clearly compromised. That note didn't just misrepresent the situation, it was dangerously misleading. Story 6. Former psych hospital worker here, we had a no list. Legally, we weren't supposed to. It's against regulations, but I can say with complete certainty that nearly every psychiatric hospital has one tucked away in the intake office. It's a list of patients who are never allowed to return. Here's something worse. If an offender is admitted to an adult unit, all patients on that unit must be notified. But if a child offender is placed on a pediatric unit, that information is considered confidential, even from the parents of other children on the ward. Yes, seriously, we weren't allowed to tell anyone. Let that sink in. Hot tip 1. Never send your child to a standalone psychiatric hospital that isn't connected to a larger medical system. These unaffiliated single-location facilities are often for-profit, and profits come first, way before your child's well-being. Hot tip 2. You are not required to send your child to whatever psych hospital the ER says accepted them. You have a choice. Use it. When it comes to reviews, psych hospitals are a total gamble. The best psych unit in our area has a 2.5-star rating. The facility I quit, and later reported to the state, has a 2.7-star rating and is actually the highest-rated psych program in the region according to Google. Star ratings mean almost nothing in this context. If your child has a therapist, ask them about the good and bad psych facilities. They'll absolutely know which ones to avoid. Same goes for adult patients. No one wants to think about psychiatric hospitalization, but if it ever becomes necessary, it's much better to have a list of safe options saved in your phone than to end up wherever you're sent by default. Story 7. Upcoding, changing, or adding medical diagnoses to increase payment from insurance is a form of insurance fraud. Billing for services not rendered is another example. There's a lot of abuse in the system, but much of it isn't intentional. It's a result of terrible staffing ratios and shortages of supplies. But what most people don't know is the massive amount of Medicare fraud happening in healthcare. Before becoming a nurse, I thought Big Pharma was the main culprit profiting off life-saving drugs. But the reality is, the entire medical sector is deeply flawed. It's exploitative toward everyone, from workers to doctors, and even more so toward patients. Massive corporations and the wealthy on both sides profit off the disabled, sick, elderly, and injured. And despite their wealth, they aren't providing the best care. They're short-staffing, withholding resources, and prioritizing profit over people. It's the worst kind of greed, profiting off people who can't defend themselves. They do everything they can to squeeze every dollar out of insurance, and we pay for it through taxes. But if you've seen what I've seen, you'd despise those corporations and their CEOs. Nurses burn out quickly because the system is abusive and exploitative for everyone in it except for those at the top. The rich CEOs and their families who have no medical education or experience get to decide what my job is worth and how little staff they can get away with to maximize profits. They set strict budgets for supplies even if that means not having enough for patient care. Yet patients or insurance are still charged for those supplies even if they don't actually exist. Medical care should not be a for-profit business unless it's strictly cosmetic. A person with no medical training should not have the power to get rich off teams of people trying to save someone's life, especially when that life could have been saved if there were enough staff to go around. Staffing shortages could be fixed quickly with the right financial incentives. Offer more money and more people will go into healthcare. Mandate better nurse-patient ratios to reduce stress and prevent burnout. Some states are making progress, but others, like Florida, are dragging their feet. Florida has one of the largest healthcare systems and retiree populations, but it's also one of the lowest paying states for nurses. They don't protect nurses from being forced to work extended hours, 16 or even 24-hour shifts. If I choose to leave after 16 hours because I need sleep, I risk having my license revoked for patient abandonment. There are states with laws that protect nurses from this abuse, but they're the exception, not the rule. And who do you think lobbies to keep things the way they are? The corporations that are getting filthy rich off the system. I'm not advocating for state-run healthcare or pushing a political agenda. I'm just telling you that the system is broken, and if you're not in it, you can't imagine how bad it is. It may be better in some states, but COVID really made things worse. Corporations doubled patient ratios during the pandemic, and now they've realized they can keep it that way. Florida, ironically, is one of the worst places to retire because the medical system is so terrible. My wife and I are trying desperately to leave, but there's no alternative for the pay that doesn't come with crushing student debt. People think nurses make a lot of money, but they don't. We make more than some, but the economy is a mess. We can't even afford a house right now with the current market. Travel nurses used to make $200K a year, but that's practically gone now, especially because those jobs required specialized experience and put our licenses at risk due to unsafe staffing. Most nurses are nowhere near making that kind of money, despite what you hear in the stories. Story 8. The people conducting your lab tests, which informs 70% of your doctor's decisions, no longer need a specialized degree or even a license in most states. This is deeply concerning. These individuals often don't have formal clinical laboratory training, which typically requires at least an associate's degree and can go up to a master's level of education. Inaccurate lab results can lead to improper treatments, and there's little you can do because doctors rely on the lab results to make their decisions. Historically, all medical laboratory results were handled by licensed, formally trained laboratory scientists. However, in recent years, fewer people are choosing this field, likely due to the pay discrepancy between lab staff and nurses, despite requiring similar levels of education. As a result, many states have relaxed the requirements and no longer mandate licensure or any form of medical lab training. This shift should be deeply alarming. Honestly, I'm terrified. Story 9. I got a few. 1. A lot of the blood work done for patients admitted for several days includes tests that are unnecessary and ultimately end up being charged to the patient or their insurance. For example, daily CBCs often serve no real purpose. 2. When a doctor says they'll change a patient's opioid pain medication, it's usually a switch from as-needed (PRN) doses to scheduled doses with the same time intervals. This means the patient ends up getting pain medication around the clock, because PRN medications are often delayed if the nurses are busy when the patient asks for it. 3. When a doctor says they'll discuss with the other consulting team, it usually just means they'll read through the other team's notes. There's rarely actual in-depth collaboration between teams for multidisciplinary care. 4. If a patient wants a doctor to discuss something in front of a family member or by phone, it's usually better to arrange that ahead of time. Doctors tend to get irritated if you ask them to repeat the same information to a family member after they've already explained it. 5. If someone is admitted for alcohol withdrawal and is being discharged back home, doctors often assume the patient will drink again, regardless of what they say during the discharge conversation. Story 10. If visitors were aware of nosocomial infections and typical hospital cleaning practices, they'd never set their purses, tote bags, backpacks, or anything else on the floor when visiting patients. They'd also likely wear shoe covers or burn their shoes when they get home. About 20 years ago, my grandmother was hospitalized for a bowel biopsy to check for a tumor. Given the nature of the bowel, the procedure was treated like any other intestinal surgery. The bowel prep included a powerful laxative that liquefies the contents quickly. The nurse warned my grandmother to stay seated on the portable toilet in the room or the fixed toilet in the bathroom. But with several family members visiting, she was too embarrassed to be seen on the toilet with everyone around. I tried to suggest we leave to give the nurse an aid space, but no one was listening. I moved to the far side of the room by the door to wait. As expected, while she was standing and chatting, My grandmother's bowels emptied suddenly. Family members grabbed their purses, bags, and backpacks, scattering as the pool of liquefied feces spread across the floor. A housekeeper entered with a broom and scoop, followed by a string mop, filling up the rolling bucket. I quietly observed. After cleaning, the housekeeper rinsed the broom, mop, and bucket in the utility room, setting them aside to be used on the rest of the ward. No real hazmat cleanup at all. Sadly, my grandmother never fully recovered. She passed just shy of her 90th birthday from complications related to an infection that never completely healed. The anesthesia and morphine had also taken a toll on her mind. Some people experience long-term dementia after surgery and opiates, and she was sharp as a tack before the procedure. Watching her rapid decline was heartbreaking. Technically, she died from congestive heart failure, but that was the result of a months-long battle with a lingering infection. The tumor, it turns out, was benign. But back then, there was no other way to biopsy a bowel tumor without invasive surgery and the complications that followed. Every time I see someone set their purse or tote bag on the checkout conveyor, I wonder where those bags have been. I'll always prefer plastic bags for food sales. Many of today's bags break down quickly when exposed to sunlight or bacteria in the soil. For context, I worked in nursing for years during the 1970s to 80s, including in the OR and dialysis, and also cared for my grandparents and mother to help them live at home as long as possible. Story 11. Hospital lab worker here. It's not exactly scandalous, but something most people don't realize is that lab test results are essentially highly accurate estimates. Every test has a margin of error. So when we report that your X level is 10G/L, it might actually mean 10G/L, 10–20%. I've seen people get really stressed over small changes in their blood work, not realizing that those fluctuations often fall within the test's natural variation. Unless the difference exceeds the reference change value, it's not necessarily a meaningful change from previous results. Story 12. Not exactly a secret, but please, if you bring your child to the hospital, do not let them crawl or play on the floor. Hospital floors may look clean, but they're far from it. We're talking about surfaces that have seen blood, urine, feces, vomit, you name it. And while they're cleaned, it's often more of a quick once-over than a deep sanitization. On top of that, think about where everyone's shoes have been. Nurses, doctors, housekeeping. We've all walked into rooms with COVID, norovirus, Group A strep, and then walked right back out and into the next space. The germs come with us. TLDR, hospital floors are disgusting. Don't let your kid touch them. Story 13. There's an entire army of pharmacists working behind the scenes, often tucked away in the basement, who review every single medication order entered by doctors. Most people don't realize how many potential errors are caught and corrected before they ever reach a patient. These pharmacists flag issues like a dialysis patient being prescribed a medication that's toxic to their kidneys, duplicate nitrate-containing meds, an elderly patient with a dangerously prolonged QTC interval being prescribed Levaquin, or an antibiotic being reordered just hours after it was already given in surgery. They notice when a high-risk patient isn't on blood thinners, when duplicate potassium orders are placed, or when a thyroid test is forgotten before starting amiodarone. They adjust doses when kidney function improves, recommend changes like switching from pantoprazole to lansoprazole because one can't be crushed for a patient with a G-tube, and request updated weights for NICU babies to recalculate their precise medication dosages. They even catch things like accidental insulin orders for 1030 units when the doctor probably meant to schedule it for 1030. These pharmacists are a critical safety net, quietly preventing potentially dangerous medication errors around the clock. Story 14. The lab. Not the place where they draw your blood, the place it goes afterward. Most people don't realize just how many labs are operating inside a hospital or how essential they are. Without them, a hospital isn't much more than a collection of educated guesses. Without the lab, it's just a bunch of doctors' offices. Every color-coded tube drawn from your arm serves a specific purpose. They must be filled to precise levels, drawn in a particular order, and sometimes even from specific sites to avoid contamination. Once collected, your samples, blood, urine, sweat, saliva, feces, fluid from wounds or organs, tissue from tumors, even removed appendages, go to the lab for testing. The lab sees everything. It knows when you're eating too much sugar, when you're not being honest about your smoking, and when you're relying too heavily on over-the-counter pain meds. It recognizes your body's silent signals before symptoms ever appear. The lab watched your platelet count drop during chemotherapy, caught the early signs of lupus, and identified that genetic mutation no one else could see. It confirmed your COVID diagnosis, then connected you with convalescent plasma programs to help others survive. It tracked your time on the heart-lung machine and made sure you got blood when you needed it. And when those stem cells finally arrived for your bone marrow transplant, the lab celebrated. Doctors and nurses may see your face, but the lab knows you from the inside out. It's often invisible, even to other hospital staff, but it's there working behind the scenes, quietly rooting for your recovery. Story 15. Nurse-to-patient ratios in many hospitals have reached dangerously unsafe levels. When a single nurse is assigned 5 or more patients, the risk of patient death can increase dramatically. Some studies suggest by as much as 60%. Hospitals are struggling to hire and retain qualified nurses, and many experienced ones have left due to low pay and overwhelming burnout. As a result, nurses are frequently given inappropriate patient assignments, meaning they're responsible for too many critically ill individuals, sometimes including patients on life support who should have one-on-one care. Inexperienced or even brand-new nurses are often thrown into complex assignments they're not equipped to handle simply because there's no one else available. Many senior nurses who used to guide and mentor have left the bedside entirely, leaving units stretched thin and unsafe. Leadership at the top, CEOs, CFOs, and other executives, often prioritize profit over patient outcomes, making staffing and safety concerns worse. Meanwhile, assaults on nurses are alarmingly high, and staff are regularly discouraged from pressing charges to avoid bad publicity. If you don't have an advance directive or living will, it's crucial to get one now. CPR isn't like it looks on TV. It's traumatic, often unsuccessful, and can leave survivors with a significantly diminished quality of life. It's something to consider carefully for yourself and your loved ones. When a nurse is scanning, hanging, or administering medications, please don't interrupt them. That moment is critical. They are performing essential safety checks, confirming the right patient, drug, dose, route, timing, and checking for allergies. It's the last opportunity to catch an error and potentially save a life. Just because you see a nurse sitting doesn't mean they're not working. They may be documenting care, reviewing physician orders, or coordinating multiple complex tasks. And despite their demanding work, nurses often go entire 12-14-hour shifts without a proper break. No meals, no water, no bathroom. If they manage to eat at all, it's often cold food inhaled in under 5 minutes. If you see a nurse or any hospital staff member running, do not stop them for a blanket, a snack, or water. They are likely responding to an emergency. And in the ER, if someone comes in actively dying, experiencing cardiac arrest, a stroke, or another life-threatening emergency, they will be treated before you, no matter how long you've been waiting. That's how emergency care works. Lastly, the ER is not the place for routine testing like STD or pregnancy tests. It's not for checking if you can drink over the holidays or for confirming a pregnancy before a family dinner. A urine test done in the ER will cost thousands of dollars and is the exact same dip test you can buy at the pharmacy for a few bucks. And if you want a blood pregnancy test, that's something your OBGYN handles, unless you're bleeding, have lost fetal movement, or are experiencing a possible miscarriage. It won't be done in the ER. Hospitals are under intense strain, and so are the nurses keeping them running. Please be aware, be kind, and be informed. Story 16. In most U.S. states, there are no legal limits on how many patients a nurse can be assigned to at one time. California remains the only state with mandated nurse-to-patient ratios, and even there the law accounts for patient acuity, requiring fewer assignments when patients are critically ill. While a few other states are in the early stages of considering similar legislation, the majority still allow hospitals to set their own staffing levels. This means nurse assignments are often arbitrary and based more on cost saving than patient safety. Hospitals routinely understaff units, conceal the data, and then shift the blame onto nurses when adverse outcomes occur. Who suffers the consequences? Patients do. Understaffing leads to a higher risk of death. hospital-acquired infections, bed sores, medication errors from rushed care, and injuries like falls when patients try to do things alone because help isn't available. Nurses are responsible for a vast number of behind-the-scenes safety tasks that are often impossible to complete when they're stretched too thin. It's a dangerous system. If you want to see what this really looks like, browse stories on forums like Roz Nursing. You'll be shocked. Research has shown that for every additional patient assigned to a nurse beyond a 4:1 ratio, the risk of patient death increases by 7%. And yet it's common for nurses across the country to care for 8, 9, or even more patients, many of them seriously ill. In some cases, it's even worse. One facility in the southern U.S. regularly staffed a night shift psychiatric unit with just one nurse and one assistant for 20 patients. And no, psychiatric patients don't just sleep through the night. There should be national outrage that there is no federal standard for safe staffing ratios. The level of care and risk you and your loved ones receive in the hospital often depends solely on where you live. That should infuriate everyone. Story 17. When choosing a hospital, don't judge solely by its appearance. Private hospitals often boast attractive decor, private rooms, and staff who have more time to cater to your needs, providing a more personalized experience. However, this doesn't necessarily mean the care is superior. Private hospitals typically cater to healthier, more well-off patients who aren't dealing with complications from drugs, alcohol, smoking, or other high-risk behaviors. As a result, they may lack experience handling severe complications. Expert care is usually found at major public hospitals, where the staff has extensive experience handling complex and rare cases. For example, the world's leading surgeons for treating gunshot wounds are at Boston's public hospital. Similarly, the best care for pregnancy complications is often found at the largest public maternity hospitals, where high-risk pregnancies and complications are more common. In many cases, if something goes wrong during your treatment, you'll likely be transferred to a major public hospital anyway. So if you're flagged as high risk, especially in pregnancy, it might be better to go directly to a major public hospital or an attached birthing center rather than risk an emergency transfer later. Story 18. Hospitals are often more concerned with money than with providing quality care, and many life-threatening mistakes, negligence, and malpractice are swept under the rug to protect the institution's reputation. I know of a nurse in my ICU who has let 3 patients self-extubate, remove their breathing tubes without facing any consequences, despite having been there for less than a year. Similarly, an ER nurse at my hospital caused a fatal air embolism, something that, contrary to TV depictions, requires much more air than just a few bubbles, often the entire contents of a syringe. This incident was also buried, and the nurse continued working there without facing any repercussions. There was a doctor in the NICU who was shaking babies, and when an RN reported the malpractice, the hospital went to court and defended the doctor with a lawyer, ultimately turning the case around to blame the nurse for negligence. As a result, the nurse lost their license and tragically took their own life after the case. This happens too often. Employees who are incompetent or dangerous often don't face proper punishment or remediation due to staffing shortages and the cost of addressing these issues. I knew an RN who, when she first started, made a mistake by putting a patient's CPAP on without turning it on, nearly causing asphyxiation. I didn't report her because, at the time, the hospital hadn't properly trained her, and she was clearly upset about it. She learned from the experience and never touched a machine she wasn't sure about without consulting me first. But even if I had reported her, nothing would have changed, because nothing ever does when safety incidents are reported. I also reported an ER nurse who left a tourniquet on a patient's arm for 45 minutes, removed a patient from a breathing machine she wasn't authorized to touch, causing them to go into respiratory distress, and ventilated a patient with the face mask upside down. I reported all 3 of these mistakes within a 2-week period. There was no remediation or change, and 3 years later, she's still working there, still making mistakes. Story 19. In the emergency department, some of the questions we ask during a history and physical exam are more related to billing codes than actual diagnostic necessity, though this usually isn't the majority of questions. In many cases, ED physicians' reimbursement is tied to how well their charts align with reimbursement guidelines. In the U.S. healthcare system, There's often a financial incentive to perform invasive procedures, even though these are sometimes necessary and other times not. Some physicians also follow the 4Fs rule when dealing with a belligerent patient, especially in trauma cases. If a patient is loud, assaultive, and drops the F-bomb 4 or more times during the initial evaluation, they may be intubated against their will. This involves sedating the patient, paralyzing them, and inserting a tube down their throat to put them on a ventilator. While it may seem extreme, the goal is patient safety. If a patient is highly uncooperative, it makes it difficult to properly evaluate and treat them, which could lead to serious complications. It's not about convenience for staff, it's about determining if the patient is just being disruptive, intoxicated, or if they may have a serious issue, like brain bleeding, that needs immediate attention. Story 20. I've encountered both living and dead roaches inside operating room suites. Thankfully, not during active procedures or anywhere near the equipment, but still, it's something to consider. Additionally, I've seen far more genitalia than I ever expected to as someone working in the pharmacy. Many surgeries involve positioning the patient in ways that expose their private areas to anyone with OR clearance, whether they're directly involved in the procedure or not. ETA, who work at the top-rated hospital in my suburb, known for its excellent patient outcomes. We're also the only Level 1 trauma ER and Level 4 designated LD6 NICU in a very large region, meaning we often receive cases from out of state and occasionally from abroad. Story 21. I deliver blood to hospitals, and most people don't realize that the blood supply in the U.S. is at critical levels. Recently, there have been nights when hospitals have requested specific blood types, and I've had to inform them that we simply don't have the supply to fill the order. It's especially tough during the holiday season, when people are less able to donate. I work in a rural area, where the nearest hospital may be an hour or more away. Keep that in mind before taking unnecessary risks. Even if you're a trauma patient, there might not be enough blood available to save your life. Story 22. I've got a few things to share. If someone is dying, we know. Refusing to put them on painkillers or an end-of-life care plan isn't going to save them. It only prolongs their suffering and causes them to die in pain. During visiting hours, yes, we may seem like we sit just sitting around on computers, but that's such because 1. We've already done everything we can earlier. 2. We're not supposed to do any treatments or personal care unless necessary during visiting hours. We don't want visitors to have to witness things like wound dressings or pad changes, so we do those when visitors aren't around. 3. We're filling out important documentation. Visiting hours are the best time to handle paperwork, as patients are spending time with their families. So please, don't think we're being lazy. We're not. The nicer you are to us, the more we'll try to give you that extra care. If you shout or abuse us, you'll get the bare minimum. Please just be kind to us. We don't get paid enough to be treated like crap. Story 23. A lot of the time I feel like the doctor, nurse, or PA taking care of you is completely incompetent. They don't know what they're doing, they have poor outcomes, and they're too arrogant to address the issues that need fixing. Some are distracted by affairs with coworkers, others are alcoholics, or they're abusing prescription medications while on the job. But I can't say that to patients. In fact, a few years ago, the hospital introduced a policy that requires staff to speak positively about other caregivers, regardless of how we feel. So I'll find something that's somewhat honest and reassuring to say to patients, which boosts satisfaction scores and reimbursement. But honestly, half the time it's just shy of being a lie. Story 24. If you and your family are kind to me, I'll go out of my way to make sure you're as comfortable as possible and do everything I can to help. However, if you're rude or your family becomes verbally abusive or aggressive, I'll do the basics to keep you alive, but I won't go out of my way to do anything extra. I'm not neglecting you, but I definitely won't want to go into your room more than necessary. Sometimes I really wish I could be honest with aggressive family members and just say, listen, we're on the same team here. You want them to get better, and I want that too. I spent years and a lot of money just to be licensed to do this. I want to take care of your loved one and make sure they go home with the best possible quality of life. Please stop fighting me and the rest of the medical team as if we're on opposite sides. We all want the same thing. Damn it. Story 25. My mother has been a nurse for 25 years and has always worked tirelessly. It breaks my heart to see her skip meals and not even take a break during her 12-hour shifts because she's so overwhelmed. Her hospital is understaffed and under tremendous stress, and as the floor manager, I'm not sure if that's the official title. She has to support the new nurses while also handling her own responsibilities. On top of that, she has to find replacements if a nurse calls in sick, but she doesn't get paid extra for all the additional work. It doesn't help that she struggles with the new charting systems. I know she's not very tech-savvy, and it worries me. She often comes home an hour after her shift ends, just to finish up work. She does it off the clock, but has even been written up for taking too long. She's constantly exhausted, both mentally and physically, and I just wish that as she gets older, she could have a less demanding job. The stories I hear about incompetence, neglect, and indifference, both toward patients and the nursing staff, are heartbreaking. Most of this is a result of administration decisions and budget cuts. Nurses are the ones who get the short end of the stick, so please be kind to them. Story 26. Patient falls are a major issue in hospitals. The problem is, insurance and the government won't reimburse hospitals for any injuries or extended stays caused by falls, so the hospital absorbs the cost. This means when a patient falls, it's a big deal for us. There's a lot of paperwork, meetings with management, and in some cases we can even get written up or fired if it happens often enough. I work on a neurosurgery unit, which is a high-risk area for falls. Our patients often have strokes or brain surgery, making them confused or impulsive, or they've had spinal surgery and are on heavy doses of narcotics. In my career, I've had 3 patients fall, and every time my first thought wasn't teen, I hope they are okay. But instead, are you kidding me? Ugh, I'm going to get in trouble for this. And when we put bed alarms on patients, some will yell at us, accusing us of caring more about liability than patient care, claiming they're fine to walk on their own. Sometimes I can't blame them because my hospital makes us put pretty much everyone on fall precautions if their Morse scale score is over 45, which is almost everyone. Honestly, I think the Morse scale is a flawed and outdated fall assessment tool. Story 27. I work at an NYCER, and I'm not exaggerating when I say that nurse-to-patient ratios are often 118, sometimes even 130 on the worst nights. I'm literally the only person responsible for taking care of all these patients, their extended families, and dealing with both complaints and true medical emergencies, especially since my techs are either off texting, hiding, or pulled away to monitor high-risk patients. The patients with the least serious conditions tend to be the biggest complainers, often threatening to leave the hospital. I always tell them they're free to go at any time. On the flip side, I've had people claim they're experiencing tense pain, but they're walking around talking on the phone and laughing. Just because you follow me around doesn't mean I'm going to give you pain medication earlier than scheduled. One time, a sickle cell patient told me the patient I was working with at the time was already dead and that I needed to give her pain meds. I told her she better leave. The curtains between beds? They're not even close to providing privacy. Isolation patients are sometimes right next to others because we're so full. If I'm running around helping someone with a bedpan or water is the least of my concerns. I work in the trauma bay a lot, and sometimes family members get so in the way that they actually impede their loved one's care. There's probably a ton more I can't even remember right now. Story 28. I think there's a lot of confusion and misinformation about certain things, especially when it comes to critical and intensive care. One of the biggest misconceptions people have is that the ICU will miraculously fix all of their loved ones' health problems. The truth is, the ICU is not a miracle worker. People often get upset when we suggest that their 450-pound grandparent, who's had uncontrolled diabetes for 20 years, is covered in severe infected wounds, is in septic shock with multiple bacteria in their bloodstream, and has been smoking for decades while on oxygen, might not be a good candidate for the ICU when they finally lose consciousness. Or when we suggest that their 98-year-old grandmother, who has pressure ulcers from being bedridden for months, should be placed on a no-code status. ICU and critical care are for helping a relatively healthy person recover from a temporary health crisis. It's about stabilizing blood pressure, improving heart function, reducing brain swelling, balancing electrolytes, and fighting infection. but it won't reverse decades of poor lifestyle choices, addiction, or advanced disease. It's not going to make a body decades younger or undo years of damage. Story 29. I'm not a doctor, but I can share what I know. Harvesting refers to the process of taking organs for transplant, and is scheduled as a specific procedure at every hospital I've worked at. We don't test the organs directly. Instead, we thoroughly test the patient before donation. Any drugs, legal or illegal, or diseases can affect specific organs, and there are too many factors to list. A good example is Tylenol. If someone overdoses on it, it can damage their liver, so we couldn't use that organ. If a person tests positive for alcohol or illegal drugs, we typically won't transplant organs like the kidneys or liver, depending on the blood levels. We also wouldn't use organs from someone who passed away from a contagious disease. The timing of when a person's system shut down is another key factor in organ donation. There are various types of donations: organs, bone, skin, corneas, blood vessels, muscles, tendons, and ligaments. Just because we may not be able to use major organs doesn't mean the donor can't still help many others. Personally, I have a donated ACL allograft in my knee. I'm extremely grateful to the donor because it allows me to walk, work, and use my leg, something I wouldn't be able to do without that donation. Story 30. In the healthcare world, we often swap patient stories and try to one-up each other. If you tell me I only have one shot at your IV, I won't miss on purpose, but I won't be upset if I have to dig around a little. I'll never neglect you, but if you or your family are overly needy, constantly hitting the call light or running out into the hallway to tell me your loved one sneezed, I won't stay in the room any longer than necessary. The little things like getting you a warm blanket or helping you get comfortable won't happen because it's emotionally draining. If you get gross and start hitting on me or ask me to help hold your dong when you can clearly do it yourself, I'll do the bare minimum and pass you off to a male nurse. Sometimes I have to guess respiratory rates. We cry when our patients die, even if we try to hide it. I may act politely concerned, but I don't want to see a picture of your poop, especially if you took it with your phone. If I think the provider in charge is unsafe or unethical, I'll still try to protect you from harm, but I won't show it. Your allergy list tells me a lot about your history. I really am doing my best to care for you, but please understand that I can't always explain delays because we're understaffed and overworked. I'm trying to provide the best care I can with the resources available. Story 31. I sup not a nurse, but I sub heard stories from nurses about situations where the patient likely wouldn't want to know the full details. Your consent was incorrect because the surgeon's office sent over an order for the wrong surgery. Your spouse was contacted after you were already under anesthesia, so they could consent to the correct procedure. The surgeon nearly operated on the wrong side for a tumor removal. The only reason you didn't end up with 2 incision points is that one nurse noticed a bruise on the opposite side of the surgery site. This led to a rushed rescue to figure out where your tumor actually was. The mix-up happened because the surgeon wrote that the tumor was on their left, rather than the patient's left, and the paperwork was submitted for the left side, almost resulting in an unnecessary incision. You stayed under anesthesia for 45 extra minutes because a new nurse accidentally threw away a bloody towel that hadn't been accounted for in the final count, making everyone think something was left inside you. Or maybe a tiny needle the size of a human hair got dropped. I've got plenty of stories like this, lots of near misses and mistakes that should have been caught hours earlier through better communication and checks at multiple levels. Story 32. People often don't trust volunteers or nursing assistants with the important task of bringing them something they need. Most patients ask for the RN when they make a request, not because they require skilled care, but because they're sick, scared, and hoping to feel like they're receiving therapy and answers that the doctor may not have provided. I get it, but it doesn't make it any easier when I have 4 other patients who are just as sick, scared, and uninformed. It can become overwhelming, and anxiety is contagious. Story 33. I'm not a nurse, but I've spent a lot of time in hospitals. There's a common misconception that healthcare professionals are immune to gossip. That's simply not true. Whether it's because you accidentally shoved a cucumber up your butt, asked a silly question, threw up everywhere, or have 10 personalities and one of them is a sassy gay man, we talk about it, and we talk about it some more. 2 weeks later, we're still talking about it. 5 years down the road, when a new person starts and we're reminiscing, we're still talking about it. We're human and we have opinions. The best we can do is hide how much your story affects us and not bring it up in front of you. Story 34. It can be really challenging to be empathetic when you're dealing with a situation where the suffering could be alleviated with some effort on your part. If you're struggling with constant pain, difficulty breathing, and have trouble even getting out of bed, it's tough not to feel for you. But when you're dealing with multiple health issues, like being close to 300 pounds, having uncontrolled diabetes, high blood pressure, and other cardiovascular or respiratory problems, and then tell me you had sausage, biscuits, and gravy, and hash browns for breakfast while washing it down with a 24 ounces Mountain Dew, it's hard to know how to help. I understand that changing habits, especially long-standing ones, is incredibly difficult, and overeating can sometimes be tied to depression or other mental health struggles. But when you're not making any effort to follow the medical advice given, to take your medications, or to adjust your behavior, it feels like there's only so much we can do. In my experience, non-compliance is far more common than patients actively participating in their own care, especially with cardiovascular or diabetic issues. It's a tough situation for everyone involved, but ultimately your health requires effort from both sides. Story 35. Hospitals and healthcare systems are poorly equipped for emergencies like hurricanes, fires, active shooters, earthquakes, and infectious disease outbreaks. They're run like businesses, with profit margins so tight that emergency preparedness gets little attention. There's often no budget for creating response plans, training staff, or running drills. Healthcare workers are already stretched thin, leaving them with little time or energy to participate in emergency planning. Hospital executives tend to prioritize profits and would rather take the risk than spend money preparing for situations they believe are unlikely to occur. Story 36. As a psychocorrections nurse, I see many individuals who commit serious crimes and then plead insanity, ending up in psychiatric hospitals rather than facing jail time. They're often held for extended periods, receiving treatment and eventually discharged back into society, effectively avoiding the legal consequences of their actions. And then they're living among us once again. Psychiatric hospitals are much more unsettling than how they're portrayed in movies. It's eerie. You witness patients talking to themselves, getting agitated for no clear reason, and many wear either jogging suits or prison-issued clothing. A significant number of psychiatric patients are developmentally delayed individuals who can be extremely violent with nowhere else to go. We frequently have to restrain these individuals, not out of malice, but because they lack the cognitive ability to understand when to stop. When they attack staff, they often don't stop, even if the staff member is unconscious. Story 37. As a junior doctor, if I or the nurses seem a bit frazzled, it's not because we don't care, it's because we haven't slept. Your surgeons, specialists, rapid response team, and anesthetists, they haven't slept either. If I seem stressed, it's because I'm working 3 hours of overtime on day 12 of a 12-day stretch, doing the job of 2 doctors. The other is out with COVID, on leave, or wasn't funded for this term. I haven't had a chance to eat, drink, or use the bathroom in the past 12 hours. And I've taken 8 calls, one of which is about a patient coding right now. Meanwhile, you're politely asking about something reasonable but non-urgent, like why you haven't heard about your outpatient appointment at that other clinic across the street, which isn't even in my specialty's wheelhouse. But since you're the first polite person I've interacted with all day, I haven't lost it yet. I'm grateful, though it could be worse when you verbally abuse me. I'm allowed to leave, but your nurse still has duties to attend to. Despite knowing I'll be back on a day shift in less than 24 hours, I recognize that my colleagues are working 7 a.m. to 6 p.m. and then face a 72-hour on-call shift over the weekend, hardly leaving the hospital, only to return on Monday. And even though my leave request was rejected 8 months ago, at least I have sick leave, and none of my friends or family expect me at gatherings. I moved 5 hours away from med school. Your health system relies on the overtime of junior doctors and nurses to keep running. It's not just a busy patch. It's like this all the time, and you deserve better. By the way, if you see me sitting behind a computer on the ward or in the ED, I'm not taking a break. That's where I'm ordering and reviewing telemetry, urgent imaging, blood work, and live clotting studies. Of all the things I do, This unglamorous task is the one most likely to save a life. Oh, and your allergies. They're in there too. Story 38. This might be controversial, but there sips a concerning lack of comprehension, literacy, and reasoning skills among some nurses. It sips alarming to think that you could go to the hospital and not know if your nurse is competent. I've witnessed nurses doing things like trying to order food for patients that contains allergens like gluten or nuts, giving clearly labeled formula to the wrong patient, assuming that if someone forgets to write an expiration time on mixed formula, it won't ever spoil, looking for sodas in the cabinet instead of the fridge, administering expired formula to NICU babies, not knowing that if they want to give a baby something that hasn't been ordered, they need to contact the provider to change the order, even after working there for years, claiming that items that were just restocked 20 minutes ago are out of stock. Ignoring the patient's label information, name, room number, MERN, and almost giving the wrong formula because it had a use first sticker. Refusing to give patients their food on time during COVID because they didn't want to enter rooms, then blaming us when the food is cold. Storing frozen breast milk in the fridge instead of the freezer, leaving it out on the counter for hours, or not telling anyone when it's just sitting in the patient's room, letting hundreds or thousands of milliliters go to waste. Waiting until 5 minutes before or 30 minutes after a scheduled feed to report running out of supplies, running out of formula that is overpouring and throwing it out, despite a patient only taking 450 milliliters when we delivered 720 milliliters, constantly asking when deliveries are coming, even though there's a sign posted with delivery times and deliveries happen around the same time every day. Coming downstairs to mix formula after hours, instead of using what was already delivered before the patient moved units. This isn't about making things idiot-proof. You'd think that after years of rigorous education and training to care for the sick, people would be able to read a sign or notice patterns, but instead they'd rather scroll through Instagram and TikTok or gossip about how their ex stopped paying child support because they stopped having physical relations. Story 39. The staff responsible for keeping the hospital clean, including in procedure areas, are dedicated and hardworking individuals. However, they are often managed by teams focused on minimizing costs. As a result, these workers may not always have the resources, proper training, or oversight needed to perform their jobs effectively. C. difficile, for example, is notoriously difficult to eliminate, and the cleaning tools and processes in place are sometimes inadequate for the task. Hospital-acquired infections are a significant and costly issue that affects everyone. Story 40. All the verbal abuse and threats of reporting this or that to your nurse are pointless. Nurses are just as screwed over by the healthcare system as you are. We see it, and we try to advocate for change, but it goes nowhere. We're not letting grandma sit in her dirty diaper because we're at the nurse's station chatting. She's left sitting longer than necessary because our nurse-to-patient ratio is unreasonably high, and we're likely dealing with someone else's emergency or bodily fluids when you're calling for a diaper change. Why is it so high? It's not a nursing shortage like they claim. The reality is they refuse to hire enough nurses for proper patient care because more staff means higher expenses. Additionally, hospitals are the only industry where CEOs don't need any background or experience in healthcare. CEOs of veterinary hospitals are veterinarians. CEOs of banks are finance experts. But hospital CEOs, they're MBAs with no medical training. Story 41. Many families will insist on their dying loved ones receiving fetal care indefinitely. I'd estimate that 95% of the patients I see who are unlikely to survive in any meaningful way have a full code order as per their family's wishes. It's as if people would rather subject their family member to endless suffering than allow them to pass peacefully. As a healthcare worker, it's incredibly disturbing to witness this cycle over and over again. I always try to be transparent with families, while staying within my role as a nurse, about the care I'll be providing and the discomfort or pain it may cause the patient, so they fully understand what they're asking for. I've had patients who are either dying or on the verge of hospice care, with families requesting invasive procedures like inserting an NG tube, a long tube down their nose into their stomach to force feed them, something similar to the inhumane treatment of prisoners. Imagine the worst, most painful COVID swab you've ever had, lasting endlessly, while someone holds you down as you beg them to stop. I always tell the family that I'll do it, but I want them to understand that it will be painful for the patient. The patient will likely resist, and I'll need to restrain them while I perform the procedure. I suggest they stay in the room, both to comfort their loved one and to witness the pain they're requesting. Hopefully, this will make them reconsider such a painful, futile option. Afterward, the patient will likely try to pull the tube out, meaning either it needs to be reinserted painfully or the patient needs to be restrained for days or even weeks. That's usually a wake-up call for families. Many nurses might simply follow orders and put the tube in without question, but I can't bring myself to torture someone's dying loved one unless the family truly understands the reality of what they're asking. I have feelings too. On a broader note, many healthcare workers experience PTSD from these situations. Personally, I believe a lot of the care we're asked to provide, particularly when it comes to futile measures, is unethical. I truly hope that as a society, we can change our perception of death. It's a natural part of life, but torturing someone to death should never be the way we approach it. Story 42. Best Hospital. Awards don't necessarily reflect the quality of patient care. They often just mean the hospital makes patients feel like they're staying in a luxury hotel, which leads to higher satisfaction ratings. Behind the scenes, however, these hospitals may lack the necessary resources to provide top-tier medical care. It's all a facade. If you're looking for the best medical care, your best bet is an academic medical center. The rooms might not be as plush, but that's because the focus is on providing access to critical resources like specialized physicians, advanced medical equipment, and essential supplies, instead of prioritizing the hotel-like experience. Story 43. I was an intern nurse in a neurosurgery ward once, and I had to assist a senior nurse in collecting a urine sample. Unfortunately, almost everything that could go wrong during the process did. 1. We were taught that urine samples should be taken directly from the urine stream, specifically from the middle of urination, not from the beginning or end. Instead, the nurse allowed the patient to urinate into a portable plastic toilet and collected the sample from the pool of urine after the patient was done. The nurse just wanted to make the beds and didn't feel like waiting for the right moment to collect the sample from the stream. 2. I pointed out to the nurse that the patient had also defecated while urinating, which happens sometimes with older patients, meaning the urine sample was contaminated with feces. She didn't seem to care at all. 3. Urine samples should be delivered to the lab within 15 minutes. I may be off on the exact time, but the point is, it needs to be quick. The nurse, however, left the sample sitting on a counter in the nurse's room for at least 2 hours. As a result, the urine sample was completely invalid in multiple ways, though the lab would never be informed of this. Later, when it came time to grade my internship, the department flunked me, likely out of spite, for pointing out the many things they were doing wrong on a regular basis. Story 44. Hospitals are severely understaffed and have become unsafe environments that put both employees and patients at risk. They've adopted business models where administrators focus on profit and cost, completely disregarding the human cost and the fact that healthcare is about caregiving. I've witnessed some truly unethical behavior from hospital administrators and executives. I've seen experienced nurses break down in tears because there simply aren't enough staff to care for their patients. There are hospital executives who walk around with God complexes and exhibit sociopathic tendencies. I've been a nurse for nearly 2 decades, working both per diem and full-time at various hospitals, and I can tell you this issue isn't isolated to one hospital or chain. It's widespread. When mistakes happen, we're instructed to cover ourselves by documenting everything to avoid being held accountable. Hospitals will gaslight patients who've received poor care, or worse, were harmed, and ignore them because the average person doesn't have the resources to sue or seek justice. Nurses can get fired over minor mistakes, while doctors who contribute to or cause negligence often get a pass. I always tell anyone I care about who's going to a hospital, write everything down and make sure you have an advocate with you. The system is broken, and it's truly a dangerous place. Story 45. I used to work for a company that provided its services for a major hospital, and let me tell you, the IT infrastructure in most healthcare settings is abysmally outdated. Scheduling maintenance is a nightmare since many systems are deemed mission critical. I've witnessed some jaw-dropping situations like the front desk computer in the emergency department running for 3 months straight without even a reboot. On top of that, so much of the hospital's IT relies on server hardware and software that's decades old and responsible for running everything. One Ethernet switch I came across had been running nonstop since 2001. Then there's the issue of medical machines still running ancient software. When I left the position, there were over 50 machines connected to the network that were still running Windows 2000. This was in 2019. A lot of these machines were vital to patient care, including X-ray, ultrasound, and MRI machines. But don't worry, everyone's personal data is safeguarded by numerous regulations. We had to ensure that all machines handling patient data were fully compliant with strict legal requirements, and this wasn't taken lightly. We didn't just have monthly compliance audits, we had weekly audits by a third-party firm to make sure everything was up to standard. Story 46. If you have insurance but face high deductibles, copays, or coinsurance and are on a lower or modest income, be sure to ask for the financial assistance forms and submit them. In nonprofit hospitals, not sure about others, there's a good chance your out-of-pocket expenses can be reduced or even waived. Having insurance doesn't automatically disqualify you from receiving financial aid from the hospital. It costs nothing to ask, and the worst they can say is no. If that happens, ask again. Story 47. Hospitals aren't always doing everything possible to save every patient who walks through the door. They're often balancing the risks with the costs. For example, if the average hospital sees 10 out of 100 patients die from pneumonia each month, and the hospital you're at sees only 1 out of 100 die, the next step is often to discuss ways to cut costs on pneumonia management. The idea is that it's not necessary to exceed the average, and preventing it at a 100% rate could be seen as wasteful. The reasoning behind this is to avoid performing unnecessary tests on everyone, but it still feels unsettling to think that we might not be doing everything we can to save lives in a hospital. Story 48. As a hospital security guard, I can tell you that people don't fully realize how overwhelming it is for hospitals dealing with the homeless. It's a daily struggle. A good number of them just want to escape the weather and get a meal, but many more are entitled, mentally unstable individuals. A lot of the homeless who don't get noticed are simply because they behave appropriately. At first I asked, why do we have to be so tough on them? The response was, because they abuse the system and create dangerous situations for those who really need help, and they bring even more homeless in, and honestly, they were right. We've had people wielding knives trying to scam money off others in the ER, changing clothes in parking lots, being abusive to staff, the list goes on. I understand feeling compassion for the homeless, predatory home loans, greedy landlords, parents who set them up to fail, and a lack of support, mentally or physically. But there is help out there. The thing is that help comes with rules. There are shelters and assistance available, but many of them refuse to follow the rules to access it. It's exhausting. It's crazy the variety of homeless individuals I've encountered. Some are the worst society has to offer, while others are incredibly intelligent. I met one who was an ex-high school teacher, another who was fluent in 3 languages and knew every word of the Star-Spangled Banner, and it's way longer than you think. It's a chaotic, heartbreaking situation where nobody truly wins. Story 49. Once you're asleep in the operating theater, it can be surprisingly unprofessional. There's usually music playing, and it's rarely anything calm or classical. My favorite surgeon blasts EDM so loud that holding a conversation becomes nearly impossible. People often walk in and out of the theater, which shouldn't happen, as it can affect sterility, and frankly, you might end up exposed while under the drapes. Once you're covered, most of us forget your name, or sometimes even your gender. You become the bilateral knee or the lap coal. It's not that we don't care about you, it's just that we see so many patients in a short period, and honestly, many of us aren't exactly people persons. We prefer our patients asleep. Story 50. Hospitals don't allocate much budget to their dietary or kitchen departments. I spent 7 years working in one, where the kitchen staff was hired through a third-party contractor. Every few years, the contract would come up for renegotiation, and each time the hospital tried to lower the budget, which inevitably led to a decline in food quality. We constantly battled a rat problem, and the plumbing was outdated and disgusting. On more than one occasion, sewage would back up near the kettles in the kitchen, and the hospital would call a plumbing company to clean it up enough to drain it. Executive chefs were constantly quitting because no one could handle the stress of delivering quality food and service with the meager budget the hospital provided. Meanwhile, the hospital would happily pay for new palm trees in the front driveway or parking lot renovations, but wouldn't spare a penny to improve the food served to patients. Everyone complained: patients, families, nurses, doctors, kitchen staff, but the higher-ups couldn't have cared less. Story 51. As someone who just left working in a mental health hospital, here are some hard truths. Calling repeatedly won't change what we can share. If your loved one hasn't signed a release of information, we legally can't disclose anything, no matter how much we want to. We wish we could talk to families, get a sense of home life, understand their baseline, and learn what medications have worked in the past. But without consent, our hands are tied. It's frustrating for everyone. Mental health hospitals are severely understaffed and often underfunded. A lot of the complaints you hear are true. The quality of meals, therapy programs, and basic care is dictated by corporations or insurance companies who never once meet the people they're affecting. We hate it just as much as you do. Sometimes we have to discharge individuals who are actively dangerous, hurting others, refusing medication, and unmanageable in care. If they're too unstable for any facility and law enforcement won't intervene, we're often left with no choice but to release them to a shelter. We once had a client who terrified staff, was rejected from every hospital in the state, and ended up back on the streets. He was a danger to himself and others, and we felt helpless. The system offered us no alternatives. If someone survives a self-offing attempt, they might find themselves admitted to a chaotic environment with people in acute psychosis or mania. It's the opposite of therapeutic, and we know it. If you're in this situation, go straight to the program administrator, because most floor staff are exhausted, heartbroken, and asking themselves, am I even helping? Mental health care in the U.S. is broken, not because frontline workers don't care, but because the people with power and money don't. Thank you for watching. If you enjoyed this video, be sure to give it a thumbs up, subscribe, and hit the bell icon so you never miss an update.